Great. Acknowledgement to some of the researchers whose work I'm citing here. I did actually ask their permission ahead of time. And also want to just thank the veterans who were willing to share their experiences for the research that I'll be referring to today. So, as some of you know, the VA set a goal to end homelessness by 2015, which seems like a fairly unrealistic, lofty goal for many reasons. And the previous Secretary, Shinseki, this was his priority that he set, and as many of you probably know, he's now been replaced by Secretary McDonald. And so it'll be interesting to see how things go in terms of housing services at the VA over the next administration. I will say what I'm observing now, I'm at the VA, I'm at the Women's Trauma and Recovery Clinic, but also doing some work in the Addiction Treatment Center. And my office was actually housed where all the housing case managers were, and they have all moved to Renton. There's a temporary site now in Renton for housing services for veterans, and they're waiting for a more permanent location, and there's been a little bit of a juggle with that, which is also providing some challenges for veterans who now have to travel not just to either the Seattle or American Lake location for services, but have to go to Renton for housing as well. And I have also seen recently some downsizing in terms of our housing staff. So I'm concerned that that trend may continue and get worse with the change in administration. I also just want to point out that most of the presentation I'll be referencing female veterans, not because MST doesn't happen to male veterans, but because the prevalence rate is quite a bit lower. A lot of the research done on MST and housing is about female veterans. So just some facts here. So about 141,000 veterans nationwide spent one night in a shelter in 2011. That was 10% women, and that was up from 7.5% in 2009. If I had to make an assumption here, I would say that the percentage has probably gone up. The work that I do, I work individually with MST survivors, and I co-facilitate groups, and I definitely see homelessness as a very prominent issue among the veterans that I serve. So another thing just to note is that women veterans are up to 4 times more likely to be homeless than non-veteran women. So just being a veteran alone increases your chances. So a little bit more background. One of the things that can be difficult when trying to get services for veterans is just fitting the eligibility criteria. And so the way that we define homelessness is often by people living on the street or living in shelters. And when we're looking at female veterans specifically, they tend to spend a lot more time couch surfing than in shelters and on the street for a variety of reasons, some being social, also because they're specifically seeking out emergency housing because they are in a domestic violence situation or have a stalker. There's very limited resources. It's a very difficult process to get into emergency housing for domestic violence and intimate partner violence. Also, a lot of veterans don't consider themselves to be homeless, even though they may fit the qualifications. So while couch surfing under some of the VA programs for housing qualifies as homelessness, veterans may not identify it in that way. So community clinics also, this is another thing that I noticed when I was working at Dawn with folks in the community, is I would ask the staff at the DV nonprofit, do we serve veterans? And they said, no, not really. And that wasn't really true. But the reason they made that assumption was twofold. One was that the staff often were asking the questions they needed to ask to know if a woman was a veteran or not. And also because a lot of women who've served in the military don't identify as a veteran. And this is actually true of veterans at large. A lot of veterans will feel that if they haven't been deployed or they haven't been in combat, they don't get the honor of having the label of a veteran. We definitely see that differently at the VA. Anybody that has served at all, we consider a veteran. But again, this is where labels can really be an obstacle in terms of getting housing to folks. So it's important to note why MST uniquely raises the risk for homelessness, and that's one of the things I'm really going to focus on. So we'll look at the prevalence of MST among veterans experiencing homelessness, characterize the connection between MST and homelessness in women, what the risk factors are, the pathways to homelessness, describe barriers to services, and highlight implications for prevention and services, including screening, trauma-informed care, and federal resources. One of the things I've taken a look at quite a bit is screening. So in 2002, the VA mandated universal screening of MST. And I made the assumption before I really dug into the literature that that meant every veteran that comes and gets services at the VA hospital gets screened for MST the first time they receive services. That's not actually true. So primary care providers, they do screen everyone for MST. Mental health providers will screen for MST, particularly if it's implicated in the report when they're meeting with clients. But the other areas of the hospital do not screen routinely for MST. So there are these gaps in our services. So for example, if a female veteran comes to the ER and she's having gynecological issues and she doesn't connect her experience with MST with those issues, then no one's going to screen for MST and she may not receive any services for that. So the way the ER is set up is really to triage and to address presenting issues. So I just want you to keep that in mind as we talk about this more, because while this talk won't be about the link between MST and physical illness and injury, there is a very strong correlation between MST and many stress-related chronic disease, like IBS and chronic pain. So veterans are screened one at a time. They can decline to respond to the screening, and if they do, they'll be questioned again about that a year later. The provider can also set a reminder to come back and ask the veteran again. And there's many reasons why veterans may not want to disclose at that time if they have experienced MST, or may not know that what they went through was what we consider MST. So I just want you to see what the actual two questions are we ask at the VA when we screen for this. So the first is, when were you in the military? When you were in the military, did you ever receive unwanted, threatening, or repeated sexual attention? For example, touching, cornering, pressure for sexual favors, or inappropriate verbal remarks. The second question is, when you were in the military, did you have sexual contact against your will, or when you were not able to say no? For example, after being forced or threatened or to avoid other consequences. These two questions were recently revised a little bit in order to include situations in which people are unable to give consent. So one of the things that the VA feels very strongly about is that only certain staff should be allowed to screen for MST. So clerks are not allowed to do so, only people who are considered clinical providers or have had the appropriate training. Another thing to note is just that we do have an MST coordinator for each VA healthcare system. So here, Seattle's VA is part of the Puget Sound healthcare system, which is actually Seattle and American Lake. So between the two, they have one MST coordinator who splits her time across the two hospitals. So when veterans come in, they can either see a PCP and be screened there. There's also posters up around the hospital about what MST is with the contact information for the MST provider, and then there's screening done within mental health. So, disclosure of MST. So, the veteran just saying that they have gone through MST is sufficient enough to state that the veteran has, in order for them to get care, mental health care related to the MST. So there's two different issues here. One is going to be providing the veteran with services like mental health or for physical health if it's related to MST. The other is a disability or a service-connected disability rating, which would give veterans a certain amount of money every month for living expenses and other things. There are two separate processes. One is the Veterans Benefits Administration. It's a long process. It's a lot more difficult to get approval for that with MST. But the process of actually coming to the hospital and getting mental health services for MST just requires that you disclose this happened to you. And if you disclose this, it's automated. A referral goes immediately to mental health providers. If you disclose that there's also physical problems that you have related or as a result of MST or that were worsened by MST, then a request can go into a physical provider, but a mental health coordinator, probably the MST coordinator, is going to have to review the case and give justification that those services are necessary. The perpetrator identity doesn't matter. So the perpetrator doesn't have to be a veteran. They don't have to have been serving. They don't have to have been on base. None of that's actually required. The service member could actually qualify for surviving MST and have been on R&R, their vacation time during service. So they don't have to be on base or actively serving as long as they are an active service member. And all of the costs for mental health services related to MST are provided free of charge by the VA. And again, as well, if there are physical conditions that are deemed related. Oh, another thing I wanted to note was just that the VA also serves active duty members. We're definitely not serving them as much as we are veterans, but it does happen, and certainly with MST as well. Okay. So the first study we're going to look at is Paveo, and this is looking at the prevalence of MST. So they did a national cross-sectional study looking at 126,598 homeless veterans who used VA outpatient care. This is from 2010. And the prevalence of MST among homeless veterans in the VA healthcare system was 40% for females versus veterans who had not survived MST. For males, it was 3% versus 1%. I think that difference for men would have been a lot larger had there been a larger sampling size. There's just a very large amount of underreporting when we do look at MST with males. Another thing I just want to note is just in general, when I look at research on MST, the numbers I'll see for prevalence rates outside, that was conducted outside of the VA versus within, will be very different because a lot of veterans don't go to the VA for care. They prefer not to. Okay, so homelessness, MST, and mental health, how is that related? Well, among homeless veterans, MST increases likelihood of many mental health issues. Some of these are going to include substance use, depression, PTSD, anxiety, schizophrenia, and other psychotic disorders, including bipolar disorders, personality disorders, and suicide. And I will say in the time that I've been at the VA, I've been there now about since June, that I mostly serve MST survivors, and there's a lot of comorbidity, a lot. It's very high. I've worked in mental health care for a long time, and I would say it's probably the highest comorbidity I've seen in terms of psychiatric disorders when serving a population. Looking at homeless veterans, higher mental health service use is definitely associated with MST experience. So looking at females, 24 visits is the average if they have endured MST versus 9 for the median. Looking at Washington in 2010, they did a matched case control study of homeless versus housed women veterans. and they did in-person and phone interviews. And I'm going to share with you some of the verbatim comments that the veterans had in the focus groups as well. So homeless women veterans were more likely than their house counterparts to have experienced MST. So we're looking the reverse of this. MST is an independent risk factor for homelessness. MST conferred 4.4 times increased odds of homelessness. MST and homelessness among women veterans, so these are the focus groups I was mentioning, and they did focus groups of 29 female veterans and identified 5 roots of homelessness. I'm going to point out a couple. The first is childhood adversity, and one of the things I want to share with you is in other research that I've done, I came across in the literature that, and it was a reputable study, that 50% of female service members experienced childhood sexual abuse before enrolling in the military. So that's a very, very high prevalence rate. And then if you compound that with being exposed to sexual abuse or harassment while in service, you can start to see where the risk of homelessness is really going to go up with this population. And then looking at adversity that veterans face once they transition back into the community. You know, historically, we haven't always done the best jobs of supporting veterans when they do make that transition. It can be very hard for them to find employment. They can have severed relationships with their family members. They're trying to juggle quite a few things at once. And so there's a lot of stress on these individuals. So what this creates is something that the authors titled A Web of Vulnerability for Homelessness. And it really does make a lot of sense. So if we look at folks already having a background in child adversity, and that background holds true for male veterans as well, then during service, being exposed to trauma and substance abuse is also very high while in service. And then coming out of the military and being exposed to adversity, severed relationships, continued substance use, unemployment, and in some cases criminal justice as well. All those compounding factors really increases the likelihood of homelessness. So I'm going to focus on a couple of these. So looking at MST re-victimization and homelessness, for most women in the focus group, sexual trauma during military service, subsequent trauma, and eventual homelessness really went hand in hand. One woman said they go hand in hand with low self-esteem and no relationships. That's definitely, isolation is a very common thing that I see with survivors of MST. I have worked with veterans who endured MST 30 years ago and still do not have existing relationships. They really stay inside their house as much as possible and avoid everyone that they can. It's really quite sad because if you think about it, these are individuals who have served our country and they already endure so much just serving, and then you add MST on top of it, and it's quite unfortunate. Another quote was talking about the cycle of homelessness, that the average is about 4 cycles for female veterans. And this woman said, it's like you start with the rape, then you go into the drugs, and drugs lead to homelessness. You regroup, you go back to the rape, you go back to the drugs, you go back to the homelessness. You go to stay with people, and they rape you. It's a vicious cycle until something stops. And I see this. I see women who are couch surfing and they have unhealthy relationships with partners who are using, and there's financial coercion, there's sexual coercion, there's continued sexual abuse, and I very much see a cycle too. I hear from veterans here in Seattle about coming forward and reporting MST, and then unfortunately their background is opened up and they're accused of adultery, they're accused of being lesbian or gay, and their reputations are dragged through the mud, and they're unfortunately dishonorably discharged. And when you're dishonorably discharged, you don't get any benefits anymore. So it's not an easy road to come forward, and for this reason, a lot of folks won't come forward while they're actively serving, and will wait till they're at the VA or longer. One of the things that I noticed was when I was at Dawn, the DV nonprofit, just how interesting it was that the criteria for housing, so if you're in a domestic violence nonprofit here, you have to be reporting intimate partner violence. So the funding we get from the county is really just earmarked for that only. Even if you are being abused by a sibling or a child, or you have a stalker, you're not going to get into domestic violence emergency housing with King County funds because you don't meet criteria. So when we're thinking about veterans who are raped and harassed by fellow service men and women, they're not going to fit that criteria. So I think a lot of women don't even really think of the DV shelters as a resource for them. And on the flip side of that, the crisis line doesn't really screen for that. There's the 211 crisis line, but there's actually a separate crisis line for domestic violence related issues specifically. So if you call 211, they route you to that crisis line, which is managed by Dawn. So this is another quote about pathways. I think if somebody could have debriefed me when I first came to the VA, you know what I'm saying? If somebody could have took the time, a doctor, to do the first debriefing of me and what happened? What happened? An overall assessment of me coming from the military. Were you sexually traumatized? Do you have somewhere to stay? What's going on at home? What are your finances like? I think that might have helped my life to be very different. So I've worked with sexual assault survivors for a very long time now, and across all the different subgroups, it's difficult to admit that you have gone through this, and it's difficult to even know how to label it. If you look at people, for example, who have been raped by their partner that they were married to, a lot of survivors don't see it as rape because of that marriage. So if we take that, we put that into the context of the military, when you sign up to serve and you're put into a unit, those fellow service members are your family. You are told that you trust them with your life and vice versa, and this is really a lifelong connection that you're going to have. So to then come forward and say, this person that I trust with my life, that's like a family member to me, did this to me, and to hold them accountable, it's very difficult to do. So there's definitely some barriers here to care. I'm going to go through each one. First is lack of information about social and psychosocial services. Second is limited access to services. And the third is lack of coordination. Across all the barriers, women in the focus groups expressed a sense of isolation. So the first, lack of information. So there just really is a lack of information about housing services and mental health services for veterans. There's also a lack of information on eligibility, location, terms of service use, and duration of stay. Participants who use the focus group, who were participating in the focus groups, actually use them as a venue for sharing information and experiences. And I definitely can see where it would be difficult to know what your options are. It's kind of like if you're already coming to the VA, then the services are there and they're accessible and we're happy to help. But a lot of people, if just depending on how they look at their service, may feel very uncomfortable about going to the VA. They may feel very wronged by the military. And so it's really important that we get community providers more integrated into the services we provide our veterans, so that you don't have to only go to the VA to find out what's out there for MST-related housing. Limited access. So One of the things that's difficult is just needing more gender-appropriate care. Where I work, the Women's Trauma and Recovery Clinic, we actually have a separate entrance and lobby for female veterans only so that they can feel safe when they come for care. But it's difficult because in our clinic is the military sexual trauma coordinator who also sees male veterans. So they're our clients as well. So then they have to stay downstairs and we have to get them, and we're trying to share this space across gender. And for both men and women, interacting with the same gender or the opposite gender can be triggering just depending on their experiences. We do have a new facility that's going to be opening soon at the VA, a very large mental health building, and hopefully my supervisor sat down with the architectural advisors and said, please get a waiting room for us and make this more inviting and more gender appropriate. So the hope is that that will happen. But every VA hospital is different. So we do have that to some extent, but not all VA hospitals do, and certainly not all communities do. The other thing that's happening where I am is we're actually moving our clinic into the outpatient clinic. So the idea is that we'll all be together as outpatient services, but there'll be a separate area for women. But space is a huge issue at the VA, so I'm not quite sure how all that's going to work out. Another major issue is geographic barriers. A lot of veterans live in rural areas, and they drive. There's plenty of clients, probably more clients actually driving from an hour further away than living in King County. So when we're thinking about housing services as well, it's very difficult to come to follow-up appointments, and not all veterans have transportation. We do provide transportation costs for appointments to a certain extent, but we have to manage that because it's a service that a lot of folks want because we refund at a good rate. There's definitely a lack of long-term housing options. So, for example, if you're going to go into emergency housing specific to domestic violence, you're not going to get more than 30 days max. And when we're looking at housing options that are provided by the VA, which I'll go through a little bit here in a minute, there's vouchers paid, there's per diem paid, so you're still working with these community providers. So often veterans are faced with the same barriers as our community members are, and transitional housing is very limited. So 30 days is not enough time to find a job, find a home, save money for your security deposit and all of that. It just isn't. There's restrictive criteria. So I definitely saw this out in the community as well as at the VA with housing. It's a lot easier to get into housing programs if you have children or if you do not have substance abuse. And the reason for that is a lot of transitional housing programs, especially within the context of domestic violence, they don't have staff trained on chemical dependency, so they just do not have the skills to be able to manage that as well. And that's really difficult because the comorbidity of trauma and substance use is very high. So, lack of gender-appropriate care and psychological safety concerns. This is another quote. I was raped in the military too, but whether you've been in a war zone, whether it's rape, whatever, you suffer from PTSD. And aftercare for women is atrocious. Even if you've had drug-related problems, they want you to get into programs with 55 men and 1 female and lock the doors on you. And I will say, when you go to the VA hospital, it's a very male-dominated setting, and a lot of our female veterans do feel uncomfortable and feel like they're googled out and harassed, and this is difficult for them. Another thing I want to say is just that I really respect the fact that staff at the VA felt comfortable enough to give me this presentation to share with you today. I know that the VA hasn't had the best press coverage lately, but I think one of the great things about the folks that I work with at the VA is they're willing to show the community and the public where the areas are we need to work on, and they're actively addressing them. So the last that we'll cover from the focus groups was a lack of coordination and continuity from screening to services. So from temporary to permanent housing, one quote was, in the temporary shelters, they don't do any exit interviews with us. If they did interviews, they would know if I'm ready or not to go. And that's the thing. It's not about whether or not you're ready. It's about just a high turnover so we can get the next person in. And just another thing to point out about that. So when I was taking calls on the crisis line for DV, it was literally a first come, first served basis. And I was there for about 4 months and probably maybe saw two families actually get to come in to the shelter because there wasn't space and the demand is so high. We have a huge lack of emergency housing here for survivors of domestic violence and then none for other kinds of domestic violence. Also a lack of services to address the transition from incarceration into the community. Another challenge for veterans can be managing money. So when you have been exposed to MST, the likelihood of you entering into an unhealthy abusive relationship goes up. One of the ways in which people can be abused is financial coercion. And it's not something that is talked about as much as I think it should be, considering how common it is. So it's very common for me to hear veterans talk about how they get a decent check from the VA due to disability or service-related disability connection, but their partner spends all of that money, or their partner spends most of it, or it's gone on drugs, or what have you. And so even if they're getting financial support that, is a good amount to live on, if they don't have the skills or the support to help manage that money, they're still at risk of being homeless. So implications and suggestions for reducing barriers. The findings from the focus group suggest that there needs to be a greater availability of women-only programs. There needs to be more attention to entry criteria, not screening out people because they don't have children or because they have a history of substance use. Tailoring more mixed gender programs to address safety concerns for women and improve continuity of care. Interventions that reflect homeless women, veteran preferences for peer support, and information sharing. We do have peer advocates at the VA in many of the mental health divisions and social work divisions. And I went online and I was looking up to check my facts. So when we talk about housing from the VA, we're really talking about HUD-VASH. I'm going to read what that stands for because it's hard to memorize. It's the U.S. Department of Housing and Urban Development and VA Supportive Housing Program. Apparently they do have peer advocates, but I haven't seen that connection at the VA. The housing services are fairly removed. They're in Renton, and whatever's happening is just very much outside, I would say, of the clinical care that veterans receive. We do have peer advocates within the hospital, but unfortunately we don't have any female peer advocates. And that's really a barrier because not only female veterans, but some of our male veterans who have survived MST prefer female providers only. The other thing that I will say is just that I think it would be nice if there was more training on trauma-informed care for housing case managers. There is some, but a lot of it is more online or reading on your own, and I think more in-person training would be helpful. For reducing barriers, we need to address victimization experience in women's histories and reduce or eliminate re-victimization post-military. So we need to provide trauma-informed care within the housing services as well. We need to screen for domestic violence, which I actually was just talking to an administrator the other day, and apparently a directive is coming down from the federal level for us to start doing universal screenings of DV at the VA. So it'll be interesting to see how that rolls out. And we need to address relationship issues. We do hold groups on relationship skills at the VA. I'm currently co-facilitating one there, and I mean, I think that the clinical services we provide are wonderful. I just think getting people in and making them aware of what we have is difficult. So reducing barriers, again, providing trauma-informed care and a holistic response to recovery. I think it would be nice if we offered more yoga, meditation, physical fitness, these other sorts of ways of building skills for recovery. So looking specifically at Washington, I just want to point out a few facts for you. One is that in 2011, a documentary was filmed called Service When Women Come Marching Home. I highly recommend it. I watched that documentary here on Veterans Day 3 years ago, and it's the reason why I decided I wanted to go serve veterans. It's a very impactful documentary. The topic of it starts on disability with female veterans, but because MST is so prevalent, that really became the second half topic for the documentary. And I think it is pretty impressive to know that we have the first female director of the Washington State Department of VA here. Her name is Alfie Alvarado Ramos, and she was very supportive of this documentary being shot within the women's clinic at the VA here in Seattle. And the film directors have tried to get permission to film in VA centers all over the country. So Washington was the only one that actually opened their doors. Looking at the numbers, so my supervisor is the MST coordinator for Puget Sound, and in 2013, as she reports, 99% of female veterans were screened for MST, 38.6% reported that they had endured MST. And if you look at the literature outside of the VA, those numbers look quite a bit higher, upwards of 70%. Also looking at how this compares nationally, 23% of women nationally report MST. And the question's been raised before of the MST coordinator here, why is the number higher here in Seattle? People assume that must be because we're doing something wrong. And her response, which I really appreciated, was maybe we're just screening a lot better. So that's one way to look at it. Looking at men, the reported rate was 11%. The last thing I'll say just about the MST coordinator is, if you think about how many, we've got a lot of bases here in Washington. We have a very high population of veterans. We have 3 MST coordinators for the whole state, which is pretty low. And I'm going to end with just telling you about 2 housing programs that are providing services for MST. Now, the interesting thing about this is this was just changed. So up until about a month ago, there actually was no housing support provided to veterans if the only thing that they reported was MST. If that was the one thing that they were receiving services for, they did not qualify for housing. That has now changed about a month ago. We're still waiting to see how that's actually going to pan out. It's a directive, so it's going to happen, but it's very new. So there's 2 different programs. One is Homeless Providers Grant and Per Diem, and the other is Supportive Services for Veteran Families. Both of them require that the veteran not be dishonorably discharged. That's a real problem because for some veterans who've survived MST, especially if they're being housed with the perpetrator, they might go AWOL, and understandably so. They don't want to stick around. They don't want to wait out several weeks or months of investigation. They just want to go. So my understanding is if that happens and they want services later, the MST coordinator can advocate on their behalf to get them services, but it is somewhat of a struggle. So this is just a little bit about the program, the first one, GBV, and I'll just point out, it's just basically grants to community-based agencies, and it's looking at transitional housing with per diem payments. The second one, supportive services for veteran families, is only for low-income families for permanent housing. and it provides for private and nonprofits. So again, when you have veterans who've survived MST, but they either don't have families, they're not low income, what have you, and they need emergency housing, there's really nowhere for them to go. So I have resources as well, and I'll make sure to share this with everybody afterwards, and I'm happy to take any questions. No questions?
I don't have a question, but I do really want to thank you for coming to speak to us. The theme for the third years in the interprofessional education course next week is interprofessional treatment of veterans. And we are going on Tuesday to Mary's Place, which is a women's shelter, which has a number of women who may be in this category. And then also in the Skagit Valley, we treat patients of Safe Harbor, and the Skagit Valley actually has a lot of veterans as well. So I think that this is really very helpful information. So thank you so much.
Thanks, everyone. Make sure you sign in on the attendance sheet and turn in your surveys. I'll send out an email later. Thank you.